from Universal Science. A warm welcome to all the participants to this forum on unleashing the power of two evening primrose oil and tocotrienol in PMS management. We are privileged today to have eminent Dr. Kiran Koti sir as well as Sandhya Saran ma'am. And we are doing this webinar under the collaboration with the AMOX team and sir's permission. So just to give an highlight about Dr. Kiran sir, he's the director and consultant gynecologist. He is the president of AMOX and he's the author of various chapters and textbooks in OBS and Gynec. He's the chief editor of textbook. So any young aspiring gynecologist who wants some publication and wants to get into textbook writing, I think he's the right person to get in touch with. He has also been a faculty and guest speaker at over 200 conferences and has got several paper awards also. With this brief introduction, I request sir to give his opening remark and then we'll proceed further. Thanks a lot. So over to you.
Thank you. Thank you. Warm welcome on behalf of AMOX to all the viewers. At the outset, I would like to thank Universal Nutrition Sciences, Manish Ji Garg, and of course Priya Chauhan for this particular collaboration that you have brought forth to. And I would like to put on record and appreciate that Dr. Sandhya Saran, who is the chairperson of the Midlife Committee of AMOX, has been instrumental in this particular webinar. So thank you over and all to UNS. And today, I think we have got a very good speaker in form of Dr. Sandhya. Dr. Sandhya is, of course, the chairperson of the Midlife Committee of AMOX, doing a good work in that particular field. And today, she would be enlightening us on the role of evening primrose oil and tocotrienol in PMS management. So I think without much ado, I'll not get between you and Dr. Sandhya, and I would request Dr. Sandhya to get on with today's program. Thank you. And I hope, wish and pray that we have good collaboration with the UNS in the future endeavors also. And I know you have a lot of good products and many of our faculty members will be interested in coordinating with you for all the webinars pertaining to your products. Thank you so much.
Sure, sir. Thanks a lot for your support and guidance, and thanks for giving us this opportunity also. Just to add on to what sir just introduced about Madam Sandhya Saran, Madam, just want to share a few more things about that. She's attached with Jupiter Hospital and Hiranandani Hospital. I think what appeals to me is that apart from all her accolades, whether she's a Young Scientist Award or whether she's the chairperson of AMO or a PCOS Society, I think she has been associated, whether it's a Miss India competition. She is a badminton gold winner and she is overall actor, singer, tracker, even an organic farmer and environmentalist. And she has got loads of prizes, including the Thane Citizen Pride Award. So with this brief intro, I pass it over to ma'am for her session. Over to you, ma'am.
Thank you so much, Dr. Garg, for the very, very kind introduction. And of course, most importantly, Dr. Kiran Kurtakoti, he has so much faith in me and I'm truly in debt to him for all the, inspiration that he gives all our members, especially in the AMOX. All the chairpersons are highly motivated to work hard. And today it is my proud privilege to speak on this particular topic. And I would like to thank the UNS team also for choosing me to throw light on this subject. And I would request Priya to share my slides. As we all know, the premenstrual syndrome is something which every gynecologist is faced with, and it's a dilemma. Today, we will be doing the unleashing the power of two, evening primrose oil and tocotrienol in PMS management. So let us see how this unfolds. As I said, the next slide, that PMS, the full form is premenstrual syndrome. It is a cyclical phenomenon characterized by a combination of somatic symptoms, psychological symptoms, which occur during the luteal phase, that is the second half of the menstrual cycle. Now, these symptoms disappear within a few days of the onset of menstruation. So predominantly we have women who are in their early 20s or even younger. After the age of 18 also, we see a lot, many of them who come with this syndrome. Sometimes it can get worse when they are in their 30s and 40s. A very severe form of PMS is known as premenstrual syndrome dysphoric disorder. that is PMDD. Now there has been a study at Karnataka at Belagavi among 420 college girls, and it is found that 86% of them had PMS, and almost 8% of women in India have been reported to have PMDD, that is the severe symptom. So now how do you deal with this? How do you understand whether you have PMS or not? Predominantly women come to us with, generally a ache, maybe throughout the body. They have a sense of bloating. That is the most common, complaint that they have. Tenderness and swelling in the breast, sometimes cramp-like feeling. They say, I feel as if I'm getting my period, but it is not yet come. But I'm feeling that malaise, irritability, headache, mood swings, fatigue, sometimes in severe cases, nausea, vomiting, anxiety, another very, very important symptom, sleep disturbances, appetite, basically a not feel good kind of a thing that they all complain, and this happens almost every cycle. So now we go on to the next one, classification. Now this is a very important slide, so I'll take some time on it because this is very useful for us as gynecologists to decide what kind of a person this one is who's presenting with PMS. Now we have so many of them. So how do we categorize them? The patient presents with PMS. She records her menstrual symptoms and effects on a daily basis for 2 consecutive menstrual cycles. Then what happens? How do we categorize them? We see whether the symptoms are cyclical, relieved by menstruation. If she has a symptom-free week and no influence on the quality of life and no additional factors, then basically we consider this as a physiological or a mild premenstrual disorder. So this does not require any treatment as such, but just counseling and reassurance is enough. On the second hand, if we have symptoms which are cyclical, relieved by menstruation, symptom-free week, but it does affect the quality of life, and there are no additional factors, then we can consider her as a core premenstrual disorder. Consider all alternative approaches to treatment. You have to not just counseling, but she will need some more treatment in this case. If the symptoms are cyclical and relieved by menstruation again, but there is no symptom-free week, and she has a complete, destruction of her quality of life, and there is existing non-menstrual condition, then you need to evaluate this patient further and treat the underlying medical, physical, or psychiatric condition. Sometimes they need suppression of ovulation. Sometimes they need combination pills also, because it can be so detrimental, and they can have something like a spasmodic dysmenorrhea also, premenstrual syndrome. So they may need to have at least complete, cycle rest for 3 months. So we consider that in these cases. Now we have another syndrome, that is symptoms are cyclical, symptom-free week, affects the quality of life, but there is no menstruation, that is absent menstruation. So this is premenstrual disorder with absent menstruation. You have to treat it as a core premenstrual disorder. Now we have another one, which you have patients who have again cyclical symptoms relieved by menstruation, symptom-free week, affects the quality of life, and she is on progestogen treatment. So in this case, sometimes it can be the progestogen which is inducing the premenstrual disorder. So you have to consider an alternative to the progestogen treatment. Now the worst of the lot is non-cyclical. That is, continuously the patient is suffering. She has no symptom-free week, constant influence on the quality of life, no additional factors. In this case, we have to basically pinpoint an underlying psychological disorder, and this may not be a premenstrual disorder. So it is better to refer her for psychological counseling or to a psychiatrist. So it is very important as us clinicians to understand properly what is exactly happening when a patient presents with these symptoms. So we have to be informed, and we have these guidelines to help us, sort of categorize the patients, and then it becomes easier for us to understand and treat them. Because the etiology of PMS is largely unknown, but several factors do contribute to this condition. Now, various theories of hormonal fluctuations during the menstrual cycle have been linked to PMS. Disproportion like estrogen surplus, progesterone deficiency. Estrogen levels fluctuate during the luteal phase, that is the second half of the cycle, and these are basically responsible for the mood changes. Now, women with PMS have been shown to have a very high prolactin level throughout the menstrual cycle. Now, this may interact with the ovarian hormones. Now, high prolactin associated with low estrogen can cause depressive symptoms. High prolactin associated with low progesterone may cause symptoms of anxiety or irritability. Next slide, please. Now, again, we have symptoms which are affected by serotonin. Now, what is serotonin? Serotonin is a mood hormone in common language, as well as GABA in CNS. Now, the PMS is likely to be influenced by the action of progesterone on the neurotransmitter GABA, opioids, serotonin, and catecholamine. A pre-existing serotonin deficiency with increased progesterone sensitivity is also linked to premenstrual syndrome. According to molecular biology studies, decreased estrogen causes the hypothalamus to release norepinephrine. As we all know, norepinephrine is the hormone which is like fight or flight hormone. It also, along with cortisol, it increases your heart rate and it triggers a decline in acetylcholine, dopamine, and serotonin, which leads to insomnia, fatigue, depression. And these are very common symptoms of PMS. And if they get exacerbated, then PMDD. So this is important to understand that the serotonin hormone, we also say that milk and tryptophan, all these things, they increase the serotonin release. So this is a feel-good hormone, but if there is a depletion in that, then definitely it causes mood swings. Now, other causes can be glucose metabolism alterations, abnormal, what is called the hypothalamic pituitary adrenal axis. Now, this axis is very important for functioning of the entire reproductive system. It controls ovulation, it controls ovarian, basically hormonal synthesis, and also it has an effect on the insulin resistance, and lot of nutritional electrolyte deficiencies and genetic factors may have a role in PMS. So it is basically more of a metabolism which is regulated by the HPA axis along with other genetic and nutritional factors. Now, there is a hormone called prostaglandin, as we all know, because when we have our labor patients, we know there's the prostaglandin which is released, which causes the contractions. Now, increased prostaglandin can also trigger many of the symptoms of PMS. So all these motility problems like, nausea, vomiting, sometimes they have diarrhea, more of anxiety. All these things can be because of an excess in prostaglandin, and also the spasmodic kind of pain, cramps, which the women experience during PMS. Now, what is the dietary and lifestyle factors? We all know that there is a lot of stress. There is a lot of lifestyle changes that we see nowadays. Smoking, alcohol consumption, substance abuse, all these things are on the rise. Many a times people have, a lot of deadlines to meet at work, or even when they have in the college or in the, high school, when they have exams, they have so much stress. So we see that they have a lot of, cups of coffee, tea, and then there is no exercise. They are just sitting on the desk, or they are just having a sedentary lifestyle. All this is compounded by the poor sleep quality. If you are sitting up, many times we see students and even youngsters, even older people, addiction to the smartphone and the devices is something which has become very common, and people compromise on the sleep because of that. So all this leads to changes in the entire metabolic system. And a fat rich diet also, we see many times that we are not counting our calories, and we are having something, maybe fried stuff or anything that contains a lot of cheese, butter, fat. So all these contribute to increasing the symptoms of PMS. Stress, as I said, it amplifies the sympathetic activity, which I just explained, the fight or flight kind of a syndrome. And this results in menstrual pain by increasing the intensity of uterine contractions. So next slide. So basically, we are having a sum of all these lifestyle factors which are contributing to PMS, and we have health-related quality of life. Now, health-related quality of life is something which is very poor, and you have only yourself to blame. That if you are not going to take care of your lifestyle, then definitely the problem is going to keep getting compounded. It will affect your academic performance, your daily activities, your occupation, your productivity at work, and also increase the visits to your doctor. So this becomes a disease burden, and that is why a correct diagnosis and management becomes very crucial. Next slide. Now, diagnosis. According to ACOG, that is American College of Obstetricians and Gynecologists, the criteria for diagnosis of PMS, if the reports have more or equal to one of the following affective and somatic symptoms 5 days before the periods in each of the 3 previous menstrual cycles. So what are the affective symptoms? Angry outbursts, anxiety, confusion, depression, irritability, and social withdrawal. Basically, we call it all that Y kind of a behavior, angry, very anxious. More of type A kind of behavior is affective symptoms. Somatic will be, what they manifest, like I said, most of them come with a sense of fluid retention, bloating, tenderness in the breast, swelling, headache, muscle pains, joint pains, sometimes swelling of the extremities and weight gain. We say that fluid retention is very largely responsible for the somatic symptoms. So all these basically are more of symptoms of fluid retention, and that is something which we have to look out for. So 3 elements that confirm the diagnosis are the symptoms being consistent with PMS. Symptoms should occur consistently only during the luteal phase. Like I said, the second half of the menstrual cycle, and a negative impact on the patient's function and lifestyle. Next slide. Now, how do you manage this? Now we have understood what are the types, how do you categorize them, what are the symptoms, what are the reasons. Now we have to understand how do you manage this. Now, first and foremost, like I said, lifestyle is very important. Being a lifestyle, proponent myself, I teach lifestyle changes. So, very important to understand the disease, counsel the patient if there are any vices or bad habits, smoking, alcoholism, substance abuse. All that needs to be addressed. You have to tell them to change their diet if they are having a very fat enriched diet, and if they are having too many calories or too much of, we call it aerated drinks, tea, coffee, anything that is excess of salt and sugar. Nowadays, we see Indians, they have a lot of sugar in their diet and also salt, top salt, table salt is something which we say that we should avoid. Then along with that, now it is not impossible for us to say don't take tension. Anybody who says don't take tension, nobody wants to take tension on themselves, but that is the environment which they are working in or which they are exposed to, which is a stressful environment. So how do you cope with that? We have to teach them the coping mechanisms. That is, try relaxation techniques, meditation. And when the symptoms are mild, counseling does work, lifestyle modification does work. But otherwise, you need to give them medication. Now, medications can be, like I said, if there are debilitating symptoms, then we can give hormonal contraceptives, progesterone, drospirenone, and a low-dose estrogen, which can help with PMS. But you have to counsel them that that can be breakthrough bleeding, breast tenderness, and sometimes very, very rare episodes of deep vein thrombosis are possible. Then we have antidepressants if the patient is seeming to be depressed or she has severe anxiety. Then we need to have some relief for the mental symptoms, but that has to be under a psychiatric guidance. But again, these things also can cause a little bit of deranged menstrual cycle, sleep problems, and decreased libido. Now, NSAIDs, as we all know, that people keep popping NSAIDs when they feel, that they can't handle things. But we have to remember that they do reduce the inflammation, block the pain, production of prostaglandins. But there are side effects like, a little bit of gastrointestinal upsets, nausea, vomiting, and also sometimes drowsiness. Diuretics are given many a times for the fluid retention, which I mentioned, swollen breasts, and also swelling in the feet. But we have to take care that they do not land up with some electrolyte imbalance, and sometimes they can cause headache and nausea. Now, GnRH analogs should be used only in very, very severe cases because they cannot be taken for a longer duration, because you need to give add-back therapy when you're giving them, and they also cause a loss of bone density. So we have to give it in very, very selected cases. They can disrupt the hormonal levels, and I said it causes depletion of estrogen, so it hot flashes, insomnia, and depressive moods can happen. So you have to be very selective in what therapy you're giving to which patients. Next slide. Now, according to the Royal College of Obstetricians and Gynecologists, this is the algorithm. Firstly, you treat them with lifestyle changes, exercise, cognitive behavioral therapy. It's very important. That is more of counseling. And accordingly, you give them the behavioral therapy. You can give vitamin B6 supplements. They are very useful because they do take care of a lot of your changes which are occurring within the cycle. Combination new generation pill, which I just explained, drospirenone, progestin combinations continuously or cyclically, or you can have only during the luteal phase. Sometimes we give date 15 to 25, sometimes we give 17 to 28. So it all depends individually on how the cycles are. Low dose serotonin reuptake inhibitors, selective serotonin reuptake inhibitors, they can also be given, like, we have citalopram, that is 10 milligrams. You can give only in selected patients. And if it is a second line treatment, we can think of giving estradiol patches, that is 100 micrograms plus micronized progesterone, 100 or 200 milligrams from the day 17 to 28, either orally or vaginally. Or you can put in an IUD, that is the LNG IUS device, 52 milligrams. That is also something if a patient says, no, I do not want to, take pills, or I do not want to be subjected to this, I do not remember to take. That is the most, common thing which we hear. I don't want to keep taking pills every day. Then they are very happy to get the device inserted, and it is valid for almost 5 years. So they have a lot of, what we say is peace of mind for that much duration. But then that has to be under counseling as to, if they are in the reproductive age group, then we have to see a lot of other factors also. Only second line of treatment, high dose SSRIs continuously or in the luteal phase. Again, you have to see which patient gets into this category, and then you can prescribe accordingly. Third line, as I said, GnRH analogs, be very careful when you're giving because they need add-back therapy. And also sometimes you can give patches like, estradiol gel combination with micronized progesterone or tibolone. Tibolone is something which was being used very commonly in the past, but now fewer people are giving tibolone. Again, it has to be given under strict, what we call it, follow. We just cannot keep a patient on a pill and then they come after 2 years or 3 years for follow-up. So only you have to see which patient is a little bit, intelligent and who will come for follow-up, then you can give these. And the fourth line, which is like almost like the drastic, absolutely, there is nothing else you can do, then you can think in terms of a surgical treatment. But that doesn't happen often. And we are able to manage many of them with medical treatment. Now, mastalgia. Now, mastalgia is what? Basically pain in the breast. So this is a common symptom which is related to the menstrual cycle. Again, it occurs during the luteal phase and resolves or decreases with the onset of menses. And 2/3 of the mastalgia is cyclical around 30 years of age. Mostly it is bilateral and diffuse, but in some cases it can be unilateral or asymmetric. And it is mostly in the outer quadrant of the breast and it can radiate to the axilla. Next. Now, again, this etiology also is undefined, but it is basically hormonal fluctuations. Like I said, increase in estrogen levels stimulates ductal elements, decrease in progesterone stimulation of stroma, concurrent increase in prolactin causes increased ductal secretion and contributes towards the pain and swelling, and association of cyclical mastalgia with the use of hormonal therapy with the resolution during the pregnancy, lactation, and menopause also justifies the hormonal etiology. Now, how do you differentiate between the different types of mastalgia? So basically you have whether the pain starts 2 weeks before the menses and improves after the onset, whether it is dull, heavy, or aching, bilateral, poorly localized, or extends into the axilla. So you have these kind of, non-cyclical also, not related to menstrual cycle, constant or intermittent, unilateral and variable. And you have unilateral, which is brought on by some activity, lateral or medial to the breast, or produced by pressure on the specific area of the chest wall. So you have to differentiate between these three types, and then we will be able to see which therapy is used for which one. Now, like I said, a detailed history and physical examination is very important, and that delineates the course of the investigation and the plan of treatment. In non-cyclic mastalgia, it's important to determine the exact underlying etiology. Only then, when you know what is the reason, then you can pinpoint it and you can treat it more effectively. But if you have something which is a little vague or you do not understand, then sometimes what happens is we try one kind of therapy, and if it doesn't work, then we go on to the next. So first and foremost, what do you do when a patient? We have so many patients. First, I would see 1 or 2 in a week. Now I see almost 1 or 2 in a day. They come with breast pain. Then you perform a physical examination. If you palpate a mass, then definitely the management changes completely. Then you will be referring, either you will do imaging first and then you will refer to the breast surgeon. If there is no mass which is palpated, and if it is a focal pain, and if the patient is younger than 30 years, then you do a targeted ultrasonography, that is we call it as sonomammography. And if it is normal, then you can just give her NSAIDs or give her counseling as to where sometimes people wear very ill-fitting braziers. So you have to tell them to have a well-fitting brazier and then see if the pain is better or not. If it's still persistent, then you can consider danazol or tamoxifen. Whereas if it is a diffuse pain and the patient does not have any risk factors, then you need not do imaging. Just give reassurance. And in spite of that, if the pain persists, then you go on to danazol or tamoxifen. But if a patient has risk factors, if she is more than 30 years of age, then you will consider mammography. So it's very important if it is less than 30 or more than 30. More than 30, definitely please try and do a mammography and rule out any other factor, because many a times you may not palpate a small cyst or a small mass, but on mammography it is evident. Now, algorithm for the management of mastalgia. Like I said, first of all, reassurance, lifestyle advice, even correctly wearing the kind of clothing which is required. And if there is a mass which you feel, then the entire management changes. You work up for the mass. But if the patient wants a treatment in spite of lifestyle changes, and if the breast pain continues, then you give NSAIDs for 3 months. And if there is a good response, then you can stop. But if the response is not optimal, then you may continue for another 3 months. Or you may give tamoxifen 10 milligrams per day for 3 months and again stop it. And in a poor response, you may continue for another 3 months. Or you can go on to danazol 200 milligrams 200 milligrams a day for 3 months. And you wait and see the response. Only as a last resort, you can think of goserelin. That is 3.6 milligrams per month for 6 months. Like I said, we do not give beyond 6 months because we need to give add-back therapy. Danazol also, by and large, we try and avoid because it has a lot many side effects. And if it is a good response, then you can either stop or you can continue for 100 milligrams per day in the luteal phase of the menstrual cycle for 3 months. Now, if she has musculoskeletal pain, then you can try oral or topical NSAIDs. And if it's a good response, then you can stop. But if again there is not good response, then you can consider injecting a local anesthetic plus a steroid into the tender site. Again, this is reserved for very, very poor responders. Now, cyclical mastalgia, the treatment is mainly reassurance, changing the lifestyle, avoid a lot of fatty food, and avoid a lot of spices, I would say, and exercise. Very important to exercise. That does help. NSAIDs in the management of mild symptoms. Along with that, you have to counsel them about the side effects which we mentioned. If the pain is severe and refractory, additional hormonal therapies can be considered, but only for short periods. Like I said, because of the side effects. Tamoxifen, we've already said, it relieves cyclical mastalgia in 70 to 90% of patients, but it causes irregular menses and hot flushes. Danazol is the only FDA approved for the treatment of mastalgia, but unfortunately, it does have features which can cause deepening of voice, menorrhagias, weight gain, muscle cramps. So it is not very well tolerated. Bromocriptine stimulates the dopaminergic receptors, blocks the release of prolactin, but lot of nausea, vomiting, dizziness, which we see in patients. Goserelin reserved for the treatment of refractory mastalgia. Again, I said it has a lot of problems of hot flashes, decreased libido, irritability, and most importantly, estrogen deprivation, that is vaginal dryness. Next slide. So now what do you do? Treatment options available for PMS and mastalgia. They, like I said, come with a lot of side effects. So what is the option? Now, evening primrose oil in synergy with tocotrienol, a natural, safe, effective solution to manage PMS and cyclical mastalgia. It is made from the seeds of evening primrose plant, and it comprises of linoleic acid and gamma-linolenic acid, that is GLA. Both of these have anti-inflammatory and pain-relieving properties. That is the most important thing. Ultimately, we want pain relief and we want relief from PMS. Now, how does this act? Now, evening primrose oil, first of all, it looks so pretty and it looks so nice that even aesthetically you feel much better looking at it. Anti-inflammatory action via increasing the PGE1 levels, decreasing pro-inflammatory eicosanoids, and inflammatory cytokines. We all know the inflammatory cytokines, tumor necrosis factor, IL-6, IL-1 beta. These are the factors which it decreases. Linolenic acid it acts on GLA, that is precursor for synthesis of PGE1, increases their levels, which in turn act on the anti-inflammatory mechanisms, and they also suppress the effect of prolactin, which interacts with the ovarian hormones estrogen and progesterone. And C, it restores the balance of GLA and its metabolites and reduces breast pain. So basically you have mastalgia, which is grossly reduced because of this decreased GLA and its metabolite, which causes the breast tissue abnormality sensitive to normal hormone levels. So all the symptoms of PMS and relief from mastalgia can be achieved by these mechanisms. Now, supplementation with vitamins aids in alleviating the symptoms of PMS. Vitamin E, we know for its robust antioxidant properties, it has a positive impact on PMS. B6 is also a factor in the final stages of serotonin and dopamine synthesis. Many studies have suggested a beneficial effect of vitamin B6 on PMS symptoms. Vitamin E beyond tocopherols. It has 8 differently structured compounds. Tocotrienols are more potent antioxidant, 40 to 60 times better potency due to their better distribution in the cell membrane lipid layers and a better free radical scavenging ability compared to tocopherols. Hence, tocotrienol will be more efficacious than tocopherol in alleviating the symptoms of PMS. And US FDA has classified A, tocotrienol, as generally safe, GRAS, that is how it has been nomenclature. A real-world study to evaluate the effectiveness of evening primrose oil in combination with tocotrienol and vitamin B6 in women with PMS. These are the findings from the PRIME study. Total patients were 510, a mean duration of 3 months. This is the first Indian study involving 105 doctors. They found a change from baseline in the PMSS score by 60% reduction, change in baseline in VS, that is the menstrual pain score, 75.2%, and the breast pain score, 82.5. A unique combination of EPO, tocotrienol, vitamin B6 administered for 3 months demonstrated a significant improvement in PMS symptoms and should be considered as a treatment option for managing female patients with PMS. This is from the Indian Journal of OBGYN. It's a very important study, and it is in 2024. Very, very recent, and I think this is something which has really opened the doors for this treatment. Now, efficacy of a combination of EPO and vitamin E and vitamin B6. Now, we have seen a lot of studies that the RCT of the combination of these versus a placebo. Now, primary outcome which we have seen, the daily symptoms report, that is a checklist of 17 premenstrual symptoms rated from 0 to 4 according to their severity throughout the menstrual cycle. Now, they showed a significant improvement in the total premenstrual daily symptom score and found effective in the treatment of PMS. So we have the chart which is telling us this is over a trial months, that is cycle 4. We are seeing how the graph, there is a relief in the symptomatology. So this is monitoring of the symptoms for 2 consecutive menstrual cycles to confirm PMS. So this is very effective, and I think patients are also very happy taking this. Clinical trials of EPO and PMS. Now we have the trial, the participants, the intervention, and the results. So in the first one, we have an RCT, and we have the number is 28, 180 milligrams GLA orally during the luteal phase, increase in GLA, DGLA in plasma phospholipid, improvement of PMS and severity and duration seen. The second one is a placebo randomized controlled trial, 80 participants, 1.5 gram EPO for 3 months, and a significant reduction in PMS severity score was seen. Third is a placebo-controlled randomized crossover study. Participants are 30, 500 milligrams EPO twice daily, starting on the 15th day of the cycle, continuing till the next menstrual period. Now, improvement in PMS score, that is breast tenderness, abdominal bloating, and breast engorgement. The fourth is a double-blind crossover placebo-controlled study of 80 participants. Both psychological and physical symptoms improved significantly. The fifth is a randomized double-blind placebo-controlled crossover study with 38 participants, 500 milligrams EPO, 8 capsules daily for 3 months. This is a slightly high dose. Reduced PMS scores after 3 months. And a double-blind study with 70 participants, 1,000 milligrams EPO thrice for 60 days, caused a significant reduction in stress symptoms, sleep disturbances, appetite for sweets, very important. Craving for sweets is something which people just cannot manage, and sore breasts and bloating. So this is again a very important clinical trial. So EPO as the first line treatment for cyclical mastalgia, breast pain, as I said, a history or detailed physical examination is very important. If the patient is less than 35 years age, then you can treat according to whether she has a mass or not, like we just enumerated. If she is about 35, do a mammogram. If it is normal, then you reassure, or sometimes you may have to give treatment. But if it is persisting pain, many a times in 10% we see that, then you document the pain using the visual analog scale, VAS. That is very important, the pain score, because sometimes we see that patients have a very low threshold to pain. So you have to categorize. It may be, that the pain is actually very less, but she is perceiving it as a severe pain. So this is documentation is important. Then evening primrose oil or a simple analgesic to provide relief in 40 to 60% of patients. If there is no relief or there are disabling symptoms, then you give danazol in selected patients. So what does the textbook say about EPO? According to the Shaw's textbook of gynecology, EPO diverts harmful PGE2 to PGE1 and replenishes CNS PGE1, suppresses irritability, depression, reduces fluid retention and mastalgia. According to Mansell and Webster's benign disorders and diseases of the breast, owing to EPO's moderate efficacy and good safety profile, it is recommended as the first-line treatment for the management of mastalgia. I have also used EPO in so many of my patients, and definitely they have all responded except for very few who had concomitant other problems also. But otherwise, it is an excellent, I would say, drug for mastalgia. According to the essentials of breast surgery, since treatment with EPO shows a high response rate, significant improvement in pain and minimal adverse effects, it is recommended as the first line treatment for cyclical mastalgia. So we have the textbooks which we all study during our, educational program, and they also reiterate that the efficacy is really good. So we have the effectiveness of evening primrose and vitamin E for cyclical mastalgia. This is a prospective study. Now this is done in 2024. It is Kumari J. et al. Effectiveness of evening primrose and vitamin C for cyclical mastalgia, where you have 1 gram BID EPO plus vitamin E 400 international units, showed superior efficacy compared to individual treatments and placebo in alleviating breast pain associated with cyclical mastalgia. So basically you have 1 gram, which is the dose which is recommended, and even vitamin E 400. So this is a combination which really does work wonders. Mean reduction in worst pain after 6 months of treatment from baseline. So EPO plus vitamin E for the treatment of mastalgia. Now this is the clinical evidence. When they have used NSAIDs as the first line, then they've used NSAID evening primrose plus vitamin E. Then they have used that along with tamoxifen. Then they have added danazol, and then they have evening primrose oil and vitamin E as the first line. So when they have compared 90.63% patients reported completed resolution with only EPO and vitamin E, thus proving to be an efficient method of treatment. Now we have to remember, when we are using 2, 3, 4 drugs and still the patient is not getting relief, then it does suggest that it is not working. So it's always better to try another one, which is, just got maybe 1 or 2 molecules. And if it is working wonders, then definitely it is time to rethink and change the therapy. So I think with that, we have enough evidence, we have studies, we have RCTs, and not many clinical trials which have suggested that this works. And I'm sure that we should start trying it. At least I do in my practice, and I have seen a lot of positive results and a lot of relief from this debilitating symptom. It is easy to say, sometimes, I see sort of people say, "Arey, kuch nahi, PMS is nothing, it will go away, it will go away." But there are people who cannot function. And if you are not able to function for almost 5 to 6 days in a month, even before the periods, then it just, reflects very poorly on your, productivity, as well as it also affects your mental and your entire, physical health. So I think this is something which we all need to look at collectively.
Sure, madam. Thanks a lot for taking us through both PMS and mastalgia and how it can be managed well in a clinical setting. We have more than 300 participants who are live online. We are just trying to collect their questions. Till the time we gather their questions, just want to check with you, ma'am. You did highlight that the number of mastalgia patients have increased from 1 to 2 per month to somewhere around 1 to 2 per day. So is it also reflecting in PMS patients, and is there any reason for sudden increase in the number of PMS and mastalgia patients?
Yes, definitely. I would say there is an increase, largely, like I said, it is because of the lifestyle. See, they are exposed to so many detrimental factors. People are not eating healthy, contrary to how much ever nutritional guidance we give them. People are just trying to find a fast, fix. So if you don't have time to cook, you don't have time. Even now we are seeing women who are working. We don't blame them, but they don't have that kind of time to sit and make a healthy meal. And not many can afford to keep buying food from outside, or source food from outside. So what happens is they just try to make, ends, maybe make something like paratha with a lot of oil. Even parathas can be made with less oil, and they can be made with healthy vegetables and something. But that kind of options which they need to explore are not being done. At the same time, timing, less sleep deprivation is a big factor, increased stress, sedentary lifestyle, again, a big culprit. So all this contributes, like we say, infertility is on the rise, hormonal fluctuations are on the rise. In fact, we see girls who are getting cycles also very irregular periods. And if they get, then they do have a lot of PMS. So it is definitely a contribution of many factors which is playing a role in hormonal imbalances, fluid retention, and which causes mastalgia and PMS.
Sure, ma'am. The other question which is coming is, on an average, how long a PMS and a mastalgia patient treatment, how long will it last? I know it should be individualized for every patient, but how long does a treatment? And is it that it's more younger age group or middle age, or it's which age group would it be? And third would be, which patients where you would consider a Nutra formulation?
See, it is very young age group has less mastalgia. They have more of hormone, they have more of menstrual irregularities. It is generally about 20 that we see. Sometimes we see increasing mastalgia after 30. especially if women have not had any children, if they've not done any breastfeeding, then we see a lot many mastalgias more in these, women. And like I said, if there is a very mild mastalgia and we can pinpoint a factor, if we can advocate lifestyle modification and if it is responding, then we do not need to give them medication. But mastalgia which is not responding to any lifestyle modification persisting, then definitely we need to give them medication. Now, medication can be any of the ones which I have enumerated. We start first of all with very low dose NSAIDs, and if they respond, then we leave them alone. If they are not responding, then we go on to a second one. We definitely need to rule out any other factor. So if they are above 30, then we do a sonomammography. And once medications start, like I enumerated so many of them, we used to give danazol, we used to give, but nowadays we do not believe in giving so many hormonal medications. I prefer giving non-hormonal. I definitely, even for my women in 30s, I start them on evening primrose oil. I tell them take it for 3 months and then get back to me after their periods. If they are better, then I still tell them to continue for 3 more months. So generally, by and large, by 6 months, I do see a lot of alleviation of these symptoms. There are very few cases where, after 6 months, they've been better. But then again, after 3 months, they've come back to me saying that, okay, again, now I have pain. That is largely because of the fact that they have not done anything else. Whatever we tell them to do, they follow all our advice only for 3 months. After that, they go back to eating wrong, doing everything wrong. So then again, they get pain. Then again, we give them 6 months. So I have not seen anybody having, absolutely no relief unless they have some concomitant other problem. And 6 months is something which by and large they do report with, 90% reduction of symptoms. By that time, we expect them to, find out the factor which is the culprit and address that. Sometimes we do continue for a year or two also.
So, ma'am, how would you advise the young gynecologists who are there on this call also, when they use a Nutra product, how soon should they expect a response and what counseling should they give to the patient so that, patient expectations are also managed well and the response is also monitored well?
Yes. So I always tell them that first of all, you have to be careful in selecting your patient. You should not you should not wrongly diagnose or underdiagnose. It should not be that she has some cyst or she has an underlying malignancy and which is not evident and it is causing a problem, or a fibroadenoma which, you cannot really palpate. So first of all, see to it that you make the right diagnosis, because breast cancers are on the rise. So I see a lot of people missing breast cancers also. So it is mastalgia may not be a predominant symptom in breast cancers, but sometimes there is something which you may miss. So it is best first you see properly, take a history, ask for a history of breast cancer or anything, hormonal cycles, everything you have to take into account. If you are in doubt, then please do a scan. And then you also, along with giving, like I said, first is always lifestyle modification. You have to you have to spend some time in counseling the person, asking her detailed history about everything, about her job, about her stress levels, about her, occupation. Everything has to be taken into account. And then you give a therapy and you tell her that it's not going to be a magic, that everything is going to disappear in a month. Tell her, give it at least 3 months. But along with that, if you take care of other factors, then it will work better. Once you tell them that, then they don't keep on telling you. Because if I tell some patients, you need to reduce your weight. If you're 90 kgs, you have to try and reduce your weight and then only it will work. And if she doesn't reduce, sometimes they come with 93 kgs after 3 months. Then I have at least a basis to tell her that only the medication cannot work in isolation. It is something which is a combination along with other factors. So then they understand better and you get better results. And then, of course, don't see to it that you call them. Maybe if not 3 months, you call them in 2 months' time also. And if they're not better, they will definitely come. So that is something which you need to, counseling is very important.
Hello, ma'am. This is Vikas Singh from Medical
Yes.
Team UNS. So you are using that evening primrose oil plus vitamin E in PMS patients.
Yes.
So how do you find the effectiveness of this combination, like evening primrose oil plus tocotrienol in PMS patients?
Yes, I find it because what we say is many a times we used to give vitamin E. That was the mainstay of treatment. We were always giving vitamin E, but that alone was never enough. So we always needed to add something. Now, giving, like you said, adding 3 or 4 drugs, which I mentioned in the presentation also, it is counterproductive because what happens is patient remembers to take only one thing and they don't take the other thing. So then the whole thing is, the entire purpose is lost. So I feel this combination is a robust combination. Like I said, each one has a role in a different manner. So it complements each other. So giving one combination which is complementing, which is more effective, is better than giving 2, 3 things in isolation and then the problem not being addressed. We give from our side, but we see compliance is also a problem. Patient doesn't take it that way. So giving at one is always better than giving 2 or 3.
Sure, ma'am. Can I also check, ma'am, what is the patient's acceptability for a nutraceutical formulation like a evening primrose oil plus vitamin E? When you prescribe them a Nutra, what is the usual reaction and what is their expectations, and how do you balance out your decision and their expectations?
See, I think patients are always happier to use a nutraceutical compared to a drug, because they feel that the side effects will be less. When we tell them this is something natural, it is made of, natural product, then they are much more happier because end of the day, we have to remember NSAIDs have so many other side effects on the renal profile, on the liver. So those, even they know that taking painkillers, taking this is not good. And even hormones which we give, they are ultimately steroids. So everybody understands that side effects of these are much more. Nutraceuticals, everybody understands that they don't have so many side effects, easily accessible, and they are more amenable to taking nutraceuticals compared to drugs.
Ma'am, after 3 months of therapy, like after prescribing the nutraceutical products, what are the major symptoms which patient get relief from, like abdominal bloating?
Major is definitely PMS, definite improvement in PMS and also mastalgia. Both I have seen. They always come and say, Doctor, abhi pain nahi hai.
Okay.
But then I
Apart
tell them,
from
nahi hai, but immediately it's not like that. After you stop, maybe again it will come. So sometimes I tell them, take for 3 more months.
definitely.
And at the same time, work on other factors. So 6 months is something which I tell them to take. Because
Sure, ma'am,
that gives a better,
Yeah, because as you highlighted that vitamin E has an antioxidant role, plus also it produces a metabolite, which is interesting. It's a complicated name, but I'll just still spell out gamma carboxyethyl hydroxychroman, which has a diuretic like an effect and which relieves all these fluid related symptoms, the somatic symptoms which occur in PMS. So we always talk about the antioxidant, but there is a metabolite which tends to relieve this fluid retention and take care of those symptoms. So just thought of sharing on that front also.
Absolutely. Main crux is the fluid retention, which causes PMS. So once that is addressed now, then everything sort of falls in place.
Sure. Dr. Kiran sir, if you're online and would like to say anything or comment, request all participants to put their questions or queries, if any, in the comment section. We'll be able to pick up from the comment section and raise it to madam. In case if your query is not addressed, you can reach out to any of our colleagues and we'll be happy to get it answered from madam also. Ma'am, anything pearls you want to share, additional pearls you want to share in a short summary kind of a thing for the audience which is out here?
So you know what? I always tell it's a drug works. We know the metabolite, we know the composition, we know everything. So I tell them vitamin D, everything is important for you. But ultimately, if you have something rosy to look forward, then you feel good factor is very important. Like the first thing I said is that evening primrose oil itself, the name is so catchy. And it is something which, makes you, when you look at it, the entire flower, when you look at it, it feels good. So, women, especially, aesthetics are very important. So I think that has a very big upper hand in therapy.
Sure, ma'am. And just one last, if I can ask you, ma'am, is I know you're very a lifestyle enthusiast yourself, as well as you are a great advocate. How do you ensure that your advice and the compliance of your patients on those advice and the outcomes is you ensure that those result in a outcome, meaningful outcome for those patients? How do you try to get better results with your lifestyle?
Yes, you know what happens is they say you should practice what you preach. So if everybody knows that, okay, madam also exercises, madam takes care of diet. So when you know you are like a role model, when you yourself are practicing, and when you put forth all your this thing and you tell them that you give them statistics that I have seen so much and this has responded and it will. And if I give them a goal that if you do this, definitely it will work. If it is not working, means somewhere you're going wrong. Then even they take it. Nowadays, people are taking their health seriously, and when it comes from a person who has had results before, then they also are more sincere. And my patients generally, I counsel them in such a manner that they are they accept, rather than forcibly trying to make them do something, they accept it willingly. That is very important.
Sure, ma'am. Just looking for Dr. Kiran, sir, if he wants to make any closing remark. Ma'am, thanks a lot for your time. We have Priya also, who, if you are okay with it, can give some closing remarks and then we wind
Yes,
up here. Will it
of
be okay?
course, of
Yeah.
course.
Over to you, Priya.
Please do.
Yeah. So first of all, thank you so much, Dr. Sandhya Saharan, for really coming over and giving your precious time to be a speaker with us. And you had given a wonderful, awesome presentation, and all the questions you really satisfied and answered them very well. Thank you so much for coming here. I thank Dr. Kiran Purti sir also, because he really, being the president of AMOGS, he helped UNS Universal Nutri Science to promote our webinar, and in collaboration with AMOGS. Thank you so much, Dr. Kiran, and we would like to collaborate with you in future as well. I thank all the delegates who have come and removed their precious time to attend this webinar. I'm indeed grateful to you, and I assure you, on behalf of Universal Nutri Science, we'll have plenty such interactive webinars even in future. In fact, you're planning on evening primrose oil, every month, one webinar. So I request you to participate with us in a big way. We'll inform you the dates and time and everything. I thank Dr. Manish and Vikas from our medical department, who have been so helpful, cooperative in doing the entire medical presentation to carry this thing so smoothly. I thank both of them from the bottom of my heart, and I really wish for your support even in future. Lastly, I thank the entire field force, because they were the ones who were instrumental in driving this entire webinar campaign by inviting all their HCPs for this wonderful session. And I look forward, therefore, their participation even in future as well. So with this, I thank everyone, and that's all. Bye.
Thanks a lot, ma'am. Thanks a
Thank
lot.
you.
Thanks to the AMOGS team also. Thanks a lot, ma'am.
Yes.
Thank you so much.
Thank you, ma'am. Have a nice day. Bye.
Thank you so much.
Thank you.